Welcome to Practical Statistics for Clinical Research. My name is Nate Hedrick. During this presentation, you will review design characteristics of two common observational study designs, cohort studies and case control studies. Describe the influence of four variables on statistical power and how they may affect sample size selection. Discuss methods of controlling for bias to maximize internal validity of retrospective cohort study. Explain the use of mean or median as the most appropriate measure of central tendency for a data set. And finally, select an appropriate statistical test to compare the rate of an outcome between two groups in a retrospective cohort study. So first things first for this presentation, the purpose of the following presentation is to provide practical guidance on key components of study design and statistical analysis for conducting retrospective clinical research. I'm a clinician, I'm not a statistician, nor am I formally trained in public health or clinical research. Nevertheless, I'm proud of the synthesis and collation of information contained within these slides, which is accurate to the best of my understanding, and I believe the contents of this presentation will be useful to other clinicians embarking on retrospective research. I encourage you to consult with a statistician or data analyst for specific recommendations regarding study design and data analysis. And as a note, the references that are contained in the bottom right-hand corner of the slides during this presentation may be a good starting point for self-directed reading on whatever the topic is at hand. So we're going to start by talking about two different types of observational study design. There are many different observational study designs, but there are two that are much more common than others, and those are the retrospective cohort study and the case control study. So a cohort is a group of subjects that is defined at a particular point in time and that shares a common experience. So in a cohort study, there is a population sample, and the patients in that population sample are grouped into cohorts on the basis of their exposure. And then those patients are followed to determine whether they experience some outcome of interest. Cohort studies are difficult to conduct if the outcome of interest is rare within the population, but it's particularly useful in cases where exposures are rare. And a cohort study can be prospective or retrospective, though we'll be focusing on retrospective cohort studies during the course of this presentation. Alternatively, a case control study groups a population sample on the basis of outcome. And so the outcome is present in a group of cases and the outcome is absent in a group of controls. And then you look retrospectively to determine what the exposures were between these two different groups. Case control studies are particularly useful for studying rare outcomes, but it's very difficult to use this study design to find association if exposures are rare. By definition, case control studies are retrospective in that the outcome has to have already occurred for you to group patients into cases and controls, and so it's not possible to do a prospective case control study. Additionally, case control studies cannot establish incidence within a population. Throughout this presentation, we're going to be using a real-world example, which is Ali Stillwell's PGY1 research project. It's titled A Comparison of Antibiotic Therapy Prescribed for Urinary Tract Infection Upon Discharge from an Emergency Department. And since we're going to be using this as an example of some considerations when designing retrospective research, I want to talk a little bit about the background for this project and the purpose so that these things are obviously going to play into our design considerations. So as background, urinary tract infection is one of the most common complaints for which patients seek medical attention in the emergency department. And there's increasing resistance rates of E. coli to fluoroquinolones and Bactrim, and this has placed an emphasis on the importance of using local resistance rates to determine empiric treatment of urinary tract infection. So at the University of Virginia, we use a lot of cephalexin for the treatment of urinary tract infections in patients discharged from the emergency department. And our purpose for this project is to determine whether this practice of using cephalexin is appropriate for the treatment of urinary tract infections in light of our local susceptibility patterns that demonstrate increased resistance to fluoroquinolones and Bactrim. So during our design process for this research project, we created a population sample in which we included patients that were discharged from the emergency department, had a positive urinalysis with greater than 10 white blood cells or nitrite, and that were treated with an antibiotic of interest. We then cohorted these patients on the basis of exposure to either cephalexin in one group or to either Bactrim or ciprofloxacin in the other group. And we followed them to evaluate for the rate of known clinical failure at 10 days after emergency department discharge, and then compared this on the basis of their exposure. So some of the design considerations that we had to think about when we were designing this retrospective cohort study was both the population sample in terms of how many patients did we need to include, how could we maximize validity by controlling or avoiding bias and confounding, and then when we're reporting our data and analyzing our data, should we be reporting the mean or median for reported data variables? Which statistical test should we have used to compare groups? And how should statistical significance be interpreted and reported in the final results presentation? So this brings us to our first assessment question. Case control studies, A, are best utilized to evaluate the association of frequent outcomes with infrequent exposures. B, are best utilized to evaluate the association of rare outcomes with frequent exposures. C, can be either retrospective or prospective. D, A and C, or E, B, and C. So the answer is case control studies are best utilized to evaluate the association of rare outcomes with frequent exposures. So recall that in case control studies, patients are grouped by outcome. And so since this outcome has to have already occurred, they are by nature retrospective evaluations. So the first design question that we addressed was how many patients should be included in our study? And so in general, when designing a research project, the sample size should be adequate to detect a clinically meaningful difference in outcome between cohorts and avoid an unacceptably high probability of either alpha or beta error. As we go through this next section, keep in mind that the outcome we're talking about is the primary outcome. When we're considering sample size and power, which we'll talk about momentarily, these are designed on the basis of your primary outcome. And so secondary outcomes don't necessarily have the same characteristics in their comparison. Sample size is therefore affected by 4 variables. These are the acceptable probability of alpha error, the acceptable probability of beta error, the effect size, and the rate of the outcome being studied. So we're going to go through these one by one, and we're going to start off with the acceptable probability of alpha error. So what is alpha error? Well, if we look at this 2 by 2 table, you can see on the left-hand side we have the result of our statistical test, whatever that is. And so if we find a significant or non-significant result. And then at the top, you can see whether or not we have a true difference. And so either there is a true difference or there is not. And we don't necessarily know this, but this is important for the conceptual understanding of what alpha error is. And so alpha error is also known as a type 1 error, and it's a false positive result. So if we look at the true difference, there is no difference, that does not exist, but we have a significant result for our statistical test. And so this is a false positive, and by convention, our acceptable alpha rate is usually set at 0.05 or 5%. So there's an important historical aside here, which is going to come into play kind of throughout the presentation as defining the way that we practice in terms of reporting statistical results today, but we don't necessarily conduct our statistical testing the same way. So to quote modern epidemiology here, the origin of the nearly universal acceptance of the 5% cutoff point for significant findings is tied to the abridged form in which the chi-square table was originally published. Before computers and calculators could easily give quick approximations to the chi-square distribution, tables were used routinely. Because there is a different chi-square distribution corresponding to every possible value for degrees of freedom, the tables could not give many points for any one distribution. The tables typically included values at 1%, 5%, and a few other levels. And so on the right, you can see a chi-square probability table reproduced from an open source statistics textbook. But this is how you used to look up a probability or p-value prior to the era of software that does statistical processing. And so on the left-hand side of this table, you can see the number of degrees of freedom. And then the upper tail is basically your p-value probability level for significance. And so 0.05 is the most commonly used one because it was published in all of these tables, and it just became an accepted threshold for reporting significance. So Recognize, if we think about our example study of comparing cephalexin to Bactrim or ciprofloxacin for the treatment of UTI, that a false positive error where we find a statistically significant difference in the case that cephalexin is not actually better would be a false positive error, and this might result in the increased prescribing of cephalexin when no actual difference in outcomes exists. And so this is why the threshold for alpha is set so low by convention, is to avoid practice-changing errors, essentially. Note that type 1 errors can also result from multiple comparisons, and subgroup analyses are particularly prone to this issue. So if you consider that we are by convention setting our false positive probability at 5% or less, then if 20 separate comparisons are run at the same alpha level, this 5%, we would expect 1 out of 20 of them to be a false positive by chance alone. And so consider this in terms of your design and how many actual comparisons you're going to conduct, because if you run 40 statistical tests, you want to consider that a couple of these might find a statistically significant difference on the basis of probability alone. So that brings us to our second variable, which is our acceptable probability of beta error. So a beta error is also known as a type 2 error or a false negative, and this is where we find no significant difference between the groups that we're comparing when a true difference in fact exists. By convention, beta is typically set at 0.2. And recognize that this is still an error, and it's important to try and minimize this type of error, but it doesn't typically create practice change in that it shows that there is no difference between groups when in fact there actually is. As a result, we're more tolerant of the false negative results, and this is reflected in the convention of using a beta of 0.2 as compared to an alpha of 0.05. So beta error is intricately related to power. Power is 1 minus beta, and conventionally this is set at 0.8. So if beta is the likelihood of a false negative, the power is the likelihood of a true positive. And so we want at least an 80% chance of finding a difference should one actually exist, and that's our power. Our third variable for sample size is effect size. And so the concept of effect size is essentially that detecting a large true difference in an outcome at a specified alpha and beta requires a smaller sample size than detecting a small difference in outcome. And so to illustrate this point, I want to consider two scenarios. Recognizing that this study design would not be ethical, consider a study in which we have patients with anaphylaxis and we take a sample of those patients and we randomize them to receipt of either epinephrine or no epinephrine, and then we follow them to determine how many of them die. The anticipated effect of epinephrine on mortality in patients with anaphylaxis is expected to be very large. So because the effect size is large, it shouldn't take a large sample to demonstrate this large effect size with confidence. Contrast that with scenario 2, where we have the same group of patients with anaphylaxis, but instead of randomizing them to a receipt of epinephrine or not, we randomize them to the receipt of albuterol or not. So albuterol is unlikely to have any real effect on mortality. So the anticipated effect is probably near 0, but assuming that it exists, it would take a very large sample to demonstrate a true difference in this small effect size with any confidence. So feasibility and clinical significance will both play a role in selecting an appropriate sample size. An effect size of 1% might be both clinically irrelevant and require a sample size of thousands of patients to detect. For example, it probably doesn't matter if there's a 1% difference in the rate of known clinical failure between cephalexin and Bactrim or ciprofloxacin groups. In general, we want to define a clinically meaningful difference in outcome that requires a sample size that could be feasibly collected given the overall potential study population and the resources we have at our disposal to actually conduct data collection and analysis. So as an example of this, recognize that the rate of known clinical failure as defined in our study methods is unknown for cephalexin and the Bactrim ciprofloxacin treated groups. That's what we're trying to determine. If we select a clinically relevant difference in outcome, a power calculation can be performed to calculate the number of patients that would be required in each group to detect this difference with a given beta. And so we can set this at 10%, 20%, 30%, whatever we think is clinically relevant. The smaller the acceptable delta, the larger the number of patients that would be required to detect this difference, and that a smaller confidence interval is required. And we can talk about this more toward the end of the presentation. And then finally, sample size is affected by the rate of the outcome that's being studied. So again, consider that the rate of known clinical failure is unknown for the cephalexin and Bactrim ciprofloxacin treated group. But apart from creating a definition for known clinical failure, we really can't change this rate. It's not something that we can manipulate in terms of our study design. So consider this as a reason for the frequency with which we see composite outcomes in clinical trials. And to make this point, a quote from this excellent article on composite outcomes, issues of statistical efficiency appear to be prominent, with composite outcomes and time to event trials leading to higher event rates and thus enabling smaller sample sizes or shorter follow-up or both. Thus, to have a power of 90% of finding a hazard ratio of 0.65 significant at the 5% level requires approximately 1,400 patients with a 20% control event rate, but only 700 patients with a 40% control event rate. So the point here is that composite outcomes can increase the control event rate, and that you might have multiple outcomes that you're looking for and grouping together. And this decreases the necessary sample size to have a particular power. That said, it may not answer the question of interest as well. So how many patients should be included after we've talked about these 4 different variables? Well, for resident research purposes or for practicing clinicians, the general answer to this question might be as many as is feasible. So sometimes we're limited more by resources than for the perfect answer to our question. Additionally, in terms of a power calculation, I think this quote is rather apt. So the calculation of an appropriate sample size relies on a subjective choice of certain factors and sometimes crude estimates of others, and may as a result seem rather artificial. However, it is at worst a well-educated guess and is considerably more useful than a completely arbitrary choice. And so the point of us going through these 4 different variables in terms of sample size is that you would need to consider each of these 4 in conducting a power calculation. And while a power calculation is definitely imperfect, it at least provides some guideline for us to aim for as researchers in terms of the number of patients that we need to collect, and in terms of making us think about considerations in our study design that might modify that sample size to be either more feasible or to better answer our clinical question. So when you're conducting your power calculation, you probably want to use an alpha error of 0.05 just by convention. Similarly, for beta, you would want to aim at 0.2 actually, so this would be a power of 0.8. For effect size, a meaningful difference in the primary outcome selected clinically is important to consider, and then you use that delta in determining your power. And then finally, the rate of the outcome being studied, you want to consider how alternative definitions of your primary outcome would answer your clinical question or affect the likely rate of your outcome. Which of the following would be expected to decrease the sample size required to detect a statistically significant difference in the primary outcome for a retrospective cohort study? A, an increased frequency of the primary outcome. B, a greater than expected effect size of the exposure on the primary outcome. C, a decrease in the acceptable beta error. D, A and B only, or E, A, B, and C. Answer is A and B only, an increased frequency of the primary outcome, and a greater than expected effect size of the exposure on the primary outcome. Recognize that decreasing beta decreases the risk of a false negative, finding no difference when one exists, and therefore this increases power, the likelihood of finding a difference when a true difference exists. However, this would be expected to require an increase in sample size if attempting to maintain the same confidence level for significance. Assessment question 3, which of the following are true regarding sample size when designing a retrospective cohort study? A power calculation can provide a perfect assessment of the sample size for a retrospective study. B, a power calculation can provide an educated guess of the sample size for a retrospective study. C, a study should not be conducted if the necessary sample size cannot be feasibly collected. D, a sample size that provides a power less than 0.8 is unacceptable for published clinical research. Or E, B, and D. The answer is B, a power calculation can provide an educated guess of the sample size for a retrospective study. So that brings us to the conclusion of part one, which was a discussion of how many patients need to be included in the sample. And now we're going to move forward to a discussion of internal and external validity and bias and confounding. So to start off, let's talk about external validity. External validity essentially applies to the question, can the results of this study be generalized to other populations? Typically, strict inclusion criteria or prevalent exclusion criteria will reduce the external validity of the study by making the study sample less representative of a real-world population of interest. So returning to our example research project, our population sample initially included patients discharged from the emergency department, had a urinalysis that was positive, and were treated with one of the antibiotics of interest. Consider if we had more prevalent exclusion criteria, though, where we excluded men, women with pyelonephritis, and women with diabetes. The likely result would be that it would be difficult to reasonably apply the results of our study to real-world patients that are in one of these groups, so that are male, have diabetes, or pyelonephritis. However, men, women with diabetes, and women with pyelonephritis might represent a large proportion of patients that are actually seen in the real-world ED setting, and so this would likely decrease our external validity. On the other hand, internal validity refers to the results of the study in terms of are they valid in that they produce an accurate answer to the research question being asked. And so the key to maximizing internal validity is minimizing bias. Again, returning to our study in those same exclusion criteria, if we included more prevalent exclusion criteria to exclude men, women with pyelonephritis, and women with diabetes, these patients have characteristics that are associated with more difficult to treat infections. And so if we exclude them, we may have a more valid answer to our question, is cephalexin appropriate for the treatment of uncomplicated cystitis, in that our groups will be more homogeneous and easier to compare with validity. So internal and external validity are a balance between each other. On the one hand, if we maximize external validity, it might make it difficult to isolate the effect of an exposure because there's heterogeneity within or between groups, but it may reflect real-world clinical challenges. And counter to that, maximizing internal validity typically requires isolation of the effect of exposure by making the sample more homogeneous to ensure similarity between cohorts at the expense of generalizing it to other patients that were excluded. So we ultimately chose to minimize the exclusion criteria to try and maximize external validity because we often treat men, women with pyelonephritis, and women with diabetes in our practice, and we wanted these results to be more generalized. So bias is important to a discussion of internal validity, and really it's important to any research project design. You want to maximize internal validity as much as possible. So bias is defined as a process at any stage of inference tending to produce results that depart systematically from the true values. So recognize that there are hundreds of different types of bias. We'll focus on just a few of these. In that they're the most prevalent types that we want to consider when designing retrospective clinical research. But for a more thorough discussion and definitions of many types of bias, you can consult the reference in the bottom right-hand corner of the slide. So the first type of bias to discuss is misclassification bias, and this is defined as when a systematic error in the measurement of exposures, outcomes, or covariates results in information quality discrepancies between comparison groups and distorts the true effect of the variable under study. So if you think about the research project that we are working on designing to compare outcomes between patients treated with cephalexin and those treated with Bactrim or ciprofloxacin, consider how misclassification of patients that actually experienced a clinical failure as having been successfully treated might impact the results of our study. And so this is going to impact the results of our study in several ways. One, it's going to reduce the outcome rate in each of our groups, and two, it's going to make it much more difficult to detect any difference between groups, much less a true difference between groups. So cohort studies are typically most susceptible to misclassification of outcome. As an example of this, think about it's fairly unlikely that we misclassify a patient in terms of the antibiotic they received because we can easily evaluate the prescription that they were given at discharge. However, it's much more difficult to classify patients as having clinical failure or not, and so this is where we're more susceptible to misclassification bias. In a case control study, it's just the opposite, in that they're typically most susceptible to misclassification of exposure rather than outcome. Additionally, recognize that misclassification bias can either be non-differential or differential. So non-differential bias is really referring to equal misclassification between groups. And so this is going to create what's called bias towards the null. Bias towards the null refers to the null hypothesis, and we'll talk about the null hypothesis and alternative hypothesis more later when we talk about statistical testing. But a null hypothesis essentially says that there is no difference between groups. And so non-differential bias is going to make it more likely that we end up accepting the null hypothesis that there's no difference when in fact there may be. Differential bias, on the other hand, is when the outcome of one cohort is more likely to be misclassified than the other, and this can create bias towards or away from the null. Second type of bias to discuss is confounding bias. And confounding is defined as when a separate variable with a non-intermediate relationship between exposure and outcome is disproportionately distributed between exposure and control groups and causes a distortion. So the key question in evaluating for confounding is whether or not the cohorts being compared are the same with respect to variables that affect the outcome. If variables that affect outcome apart from the exposure of interest differ between the two cohorts or three cohorts, this may bias the apparent relative risk or odds ratio for the outcome away from the true values. So again, returning to our example, recognize that the two cohorts in this study are not completely identical in terms of baseline characteristics. In most retrospective research, you aren't going to have baseline characteristics that are perfectly balanced between cohorts, which is the reason for randomization and prospective research. For example, patients that were treated with Bactrim or ciprofloxacin in our study were more likely to have a documented allergy to beta-lactam antibiotics. The results may be susceptible to confounding if one reasonably believes in this case that the allergy status of included patients influenced the rate of clinical failure. A third type of bias is called confounding or bias by indication, and this is defined as when subjects are more likely to be exposed to a factor, so exposure is dependent upon a second attribute that's associated with outcome, and this is often the indication for exposure. So consider in our study that Bactrim and ciprofloxacin may have been selected for patients that had complicated urinary tract infections or pyelonephritis, in that the indication for treatment was actually the reason that they were selected. Additionally, complicated urinary tract infections and pyelonephritis have been associated with an increased risk of clinical failure. And so this can actually create confounding by indication where exposure to Bactrim and ciprofloxacin is really due to characteristics of the infection that are associated with the outcome rather than an arbitrary choice between the two. So given these different types of bias that we've discussed, how can we modify our study design to control for bias and confounding? Well, randomization is the gold standard here, but it's not practical or not possible for retrospective research. Nonetheless, randomization is used to attempt to balance variables that may affect outcome other than the one under study between groups. And its primary advantage is that it can balance both known and unknown confounders. So the methods that we use for controlling bias and confounding in observational research that we discuss later are only really useful for controlling known or suspected confounders. And so that's why we need to carefully consider the different factors in our research design. So in a population sample, you would prefer to randomize patients to treatment such that you balance both known and unknown confounders between groups. But this isn't possible in retrospective research, so we have to turn to some other methods. First of these is restriction. So restriction is one of the easiest and most robust methods of minimizing bias in observational research. It refers to the creation of exclusion criteria for subjects with known potential confounders. For nominal variables, this often involves restricting them to a single category, so for example, only including women, or for continuous variables, restricting them to a particular range, so for example, including only patients that are aged 40 to 50 years old. The advantages of restriction as a strategy for minimizing bias and confounding is that it's incredibly easy, very quick, and cheap to conduct. The main trade-off with restriction is that it decreases your potential sample size. So consider that if your potential population that you can draw patients from is fairly close in size to the sample size that you're looking for, the more patients you restrict, the smaller your sample size gets and the smaller your power is going to be. And so this can be an issue if the total available population sample is nearly the same size as the desired sample size. Additionally, restriction has the disadvantage that it may decrease external validity in that you are making the population under study less like the overarching real-world population. Another strategy that can be used is matching. And so matching is defined as selection of a reference series, in this case unexposed subjects in a cohort study, that's identical or nearly so to the index series with respect to distribution of one or more potentially confounding factors. Matching is only effective in minimizing confounding by the factors on which subjects were matched. And really the principal difficulty with matching, I guess there are two of them. The first is that it requires a lot of time to match subjects in a cohort study, particularly for large samples. And then secondly, matching has to be done thoughtfully to avoid introducing bias and confounding. So I would recommend that you start by looking at the reference in the bottom right-hand corner of this slide for some more information regarding matching in both cohort and case control studies, if this is something that you're considering doing in terms of your own retrospective research. And then finally, we need to be really careful about the way things are measured in retrospective research. So consistent measurement is critical. All exposures and outcomes must be evaluated in exactly the same way across cohorts. So to illustrate this point, consider a study that's evaluating the diagnosis of new DVT as the outcome. If one cohort is systematically evaluated for DVT with ultrasound while the other group is evaluated on the basis of incidental identification in the routine course of clinical care, there's a difference in measurement, and the rate of the primary outcome may differ between the groups due to differences in this measurement, not due to differences in the actual proportion of subjects experiencing the primary outcome. So, assessment question 4 related to minimizing bias and confounding. The Institutional Review Board for Health Sciences Research is reviewing the submission for a retrospective cohort study to evaluate the rate of deep vein thrombosis in patients treated with the weight-adjusted prophylactic subcutaneous heparin dose as compared to a standard fixed dose of subcutaneous heparin. As a component of the proposed study design, the investigators have chosen to include only patients with weights greater than 120 kilos. Exclusion of patients with weights less than 120 kilos is a strategy known as blank. This strategy would be expected to blank internal validity while potentially blanking external validity. So exclusion of patients with weights less than 120 kilos is a strategy known as restriction. This strategy would be expected to increase internal validity while potentially decreasing external validity. So we have talked about how many patients need to be included in our population sample, and we've talked a little bit about bias and confounding and how we might employ some different strategies to avoid them or control for them. So now we need to talk about our actual data reporting in terms of should the mean or median be reported for data variables? What statistical tests should we be using to compare groups? And how should we report and interpret the statistical significance of our selected statistical tests? So to start this section, we need to talk about different types of data. It's critically important to understand the different types of data. They will affect our selection of an appropriate measure of central tendency and dispersion, which is a component of descriptive statistics, and they'll also affect an appropriate statistical test when comparing groups, so our selection of our inferential statistical test. In general, data can be split into two broad groups, categorical data and continuous data. Categorical data can further be divided into nominal data and ordinal data. Nominal data are those that can be categorized but not measured, and there's no implied rank or order, and it's essentially arbitrary. Examples of nominal data would be gender, so male or female, yes/no responses, and blood types. Ordinal data have categories that have an implied order. The interval between categories is not necessarily the same, however, and so examples of this would be pain scores or a Likert scale. And so consider the interval being very important here. In terms of a pain score, someone who has a pain score of 2 is not twice as much as a pain score of 1 necessarily, and the interval between a 1 and a 2 for a person might be different than that between a 6 and a 7. So the alternative to categorical data are continuous data, and these can be subdivided into interval or ratio data. Interval data have a defined unit of measurement, and the interval between units is constant. So an example of this is temperature. On the other hand, ratio data have a defined unit of measurement with an interval between units that's constant, but they have an additional importance factor in that they have an absolute zero value. So consider temperature is interval because zero temperature doesn't mean that there's an absence of temperature. On the other hand, zero time in terms of 0 minutes is an actual absolute zero value, and so that gives us ratio data. So when we're considering our measure of central tendency or the statistical test that we're selecting, we need to think about the different types of data, and we'll go through a couple examples of this. So let's start by talking about measures of central tendency. In general, there are 3 measures of central tendency. They're mean, median, and mode. We're not going to talk about mode because it's not particularly important to the reporting of results in retrospective research, but mode is simply the data element that comes up most frequently in a data set. Mean is appropriate for continuous data, and it is significantly affected by outliers and skewed data distributions. Mean is typically reported with standard deviation as a measure of dispersion. The alternative to mean would be median, which is appropriate for ordinal data in addition to continuous data. It is less affected than mean by outliers and skewed distributions, and it might be the most appropriate measure in skewed data distributions for this reason, which we're going to talk about more. Median is typically reported with interquartile range as a measure of dispersion. As an example of selection of measures of central tendency, this is data from the research project on cephalexin versus Bactrim and ciprofloxacin. And so this is a simple histogram of patient weights for patients that were included in the study. And so the first question we need to ask ourselves is what kind of data are weights? Because this is going to be important to selecting our appropriate measure of central tendency. Well, weights are continuous data, and then further, they are ratio data because they have a defined unit of measurement, in this case kilograms. The interval between units is constant, also true, 1 kilogram is exactly half as much as 2 kilograms. And 3, there's an absolute zero value, so 0 kilograms is the absence of any weight. So now that we've identified this as being continuous ratio data, we need to figure out what measure of central tendency to use. So the data appear in this distribution, this histogram, to have right skew, and you can see that there's a little bit of a tail of data elements to the right there, and this overlaid black line is a normal distribution, and so you can just see that it has a little heavier data element on the right than on the left side of that curve. So the next step would be to calculate the mean and the median. So the mean of this data set is 82 kilograms, while the median is 79 kilograms. And so even though these data appear to have some rightward skew and that there's a little bit of tail of data to the right, the mean and the median are very close together. And so this suggests that these data actually aren't very skewed. In general, when we talk about right skew or saying something has a tail where there are a small number of values that are far to the right of the rest of the distribution. In the case of significant rightward skew, what you see is that your mean is significantly to the right of the median. And so in those circumstances, we need to think more about what the best measure of central tendency to report and discuss would be. In this particular instance, it's probably appropriate to use and report either the mean or the median as the best measure of central tendency. In samples that show significant skew, you want to consider which one you really want to compare and discuss. So the mean is going to be more affected by that tail of the data, and the median may be most appropriate for skewed data sets. But you have to consider this on a case-by-case basis. So assessment question 5, the mean of a sample data set is A, sensitive to outliers, B, insensitive to outliers, C, appropriate for continuous data only, D, A and C, or E, B and C. So the answer is A and C, the mean of a sample data set is sensitive to outliers and appropriate for continuous data only. So returning to this alternative scenario of skewed data distributions, consider a study sample that has a more dramatic tail and right skew. And so this is just a graphical representation of what the sample distribution might look like. In this circumstance, the median is going to be to the left of the mean. Again, this is a rightward skewed data distribution. In this situation, median might be a better measure of central tendency as the mean is significantly affected by a small number of data points that are far to the right of the body of the distribution. A couple examples of this type of distribution, these are actually fairly common in healthcare settings, but one would be consider time to antibiotics from sepsis alert. So we have the sepsis alert process, and most patients probably have gotten their antibiotics by our 1 hour clinical goal. However, there are going to be some patients that have significant delays in time to antibiotics. Additionally, cost in healthcare can sometimes have a rightward skew in that many patients have relatively low medical costs for an encounter, but there's a group of patients that have extremely high medical costs, and so they're far to the right of the body of the distribution. In this situation where mean and median are well apart from each other, you need to consider which value is most appropriate for the discussion of your results. There's really no point in conducting students' t-test, which compares means, if you really want to discuss the median and talking about your results. Instead, you would report the median and the interquartile range, and then use an appropriate non-parametric statistical test to compare the two groups. And so that's what we need to talk about now is normality and parametric testing and how we're going to go about selecting an appropriate statistical test for whatever the outcome of interest we're comparing is. So to start, the normal distribution is a bell-shaped curve that has a mean, median, and mode that are at the same value. It's additionally symmetrical about the mean, and you find that 68% of values fall within 1 standard deviation of the mean, 95% within 2, and 99% within 3. And so this is a very specific data distribution, and many data sets that we're going to be working with in retrospective clinical research are not going to fit a normal distribution. So the question is, how do we deal with these data sets that have non-normal distributions in terms of selecting a parametric or non-parametric test? Important to this question is the central limit theorem. So the central limit theorem is a core theorem at the foundation of inferential statistics. And when we talk about statistical testing with the null hypothesis and alternative hypothesis, we're talking about inferential statistics. The central limit theorem essentially states, given that certain assumptions are met, that as the number of samples gets larger, the distribution of sample means approaches a normal distribution, even if the population from which the samples are drawn is not normally distributed. And so essentially, to restate that, the central limit theorem is going to give us permission to override assumptions of normality as our sample size gets larger, because statistically, when you're pulling sample means, the assumptions are going to be met anyway with a large enough sample. In practice, the skewness of the population data set is going to affect the sample size that we need to apply the central limit theorem and override the need for normally distributed data. Application of the central limit theorem allows us to use parametric tests even when the sample does not appear to be normally distributed. We'll talk about why that's important on the next slide. But likely this requires at least a sample size of 30 samples in non-skewed populations, and it might require 100 or more samples in moderately skewed populations. It's unfortunately difficult and controversial to say at what sample size this should be applied in real-world clinical research. And so again, you're going to have to consider it on a case-by-case basis and reach out for expert assistance if you're really stuck. So Why is the central limit theorem important? Well, parametric testing, by definition, assumes that the data that are being analyzed meet some assumptions of normality or adherence to the central limit theorem in their distribution. Non-parametric tests do not require assumptions about the population probability distribution. But for a given sample size, a parametric test is expected to produce a more accurate estimate of outcome probability and higher statistical power as long as the assumptions for the test are met. So in terms of our ability to find a true difference should one exist, we can increase our statistical power by using a parametric test when it's appropriate as compared to a non-parametric test. I will, however, say that the difference in power between parametric testing and non-parametric testing is probably relatively small. And in circumstances where you have a choice between either using a non-parametric test and meeting sample size considerations or using less patients and conducting a parametric test, it's much better for statistical efficiency to maximize your design on the basis of your power calculation and sample size that we discussed earlier, rather than just trying to use a parametric test to make up ground. So non-parametric testing must be used for nominal or ordinal data. So when we're talking about the use of parametric versus non-parametric testing from this point forward, we're really referring to continuous data. Using a parametric test when a non-parametric test should be used is one of the most common errors in statistical methods. For continuous data, parametric tests are unlikely to meet assumptions for use when the sample size is less than 30. For samples that are greater than 30, it's reasonable to consider parametric testing. You should probably plot the data and look with visual assessments to evaluate for skewness. Additionally, if there is clear skewness to the data or the mean and the median are very different, it would probably be best to assume that it doesn't meet the assumptions for parametric testing and use a non-parametric test, particularly if your sample size is less than 100. When in doubt, non-parametric testing is a conservative choice. And there may also be times that you specifically want to report the median rather than the mean. For example, skewed data like we talked about in terms of cost or time to antibiotics, for example. And a non-parametric test may be a reasonable choice despite meeting sample size assumptions of the central limit theorem, even in these circumstances. Recognize it's outside the scope of this presentation, but there are also ways to use statistical software packages to determine whether a sample meets the assumptions of normality in parametric testing. So for each parametric test, there's a non-parametric substitute. We'll talk more about selecting statistical tests later, but as an example, a parametric test that compares means of two sets of independent samples of continuous data to determine if they're statistically significantly different from each other is the independent sample t-test, also known as student's t-test. This parametric test requires assumptions about the data distribution. If you can't meet those assumptions or you're unsure, then a non-parametric test that would make essentially the same comparison is the Mann-Whitney U-test, also known as the Wilcoxon-Rank sum test. And this compares the medians or really distributions of two sets of independent samples also to determine if they're significantly different from each other. So that brings us to assessment question number 6. Which of the following statements is correct? When their assumptions are met, parametric tests are likely to have greater power to detect a difference than their non-parametric equivalents. B, it is always wrong to use a non-parametric test when the assumptions for parametric testing are met. C, non-parametric tests should not be used for nominal or ordinal data. D, none of the above, or E, A, and B. Correct answer is A. When their assumptions are met, parametric tests are likely to have greater power to detect a difference than their non-parametric equivalents. So now we're going to talk about selecting an appropriate statistical test and then moving into presentation of results. So a quick historical aside here as well in regards to student's t-test. I always assumed that student referred to a student in the classroom, but in fact it is quite different than that. So at the turn of the 19th century, Arthur Guinness Son and Company, and it's that Arthur Guinness Son and Company, became interested in hiring scientists to analyze data concerned with various aspects of its brewing process. William Seeley Gossett was to be one of the first of these scientists, and so it was in 1899 he moved to Dublin to take up a job as a brewer at St. James Gate. Gossett published 22 papers. Up until just before World War II, Guinness would not allow its employees to publish under their own names, and hence Gossett chose to write under the pseudonym of Student. And so Student's t-test refers to one of these papers that William Seeley Gossett wrote, and it was largely Guinness was largely responsible for some of the major advances of statistics in the 19th century, or 20th century, I guess, because of statistical evaluations of yeast. So back to the practical topic at hand, which is selecting an appropriate statistical test. Note that there are many resources available that may help select an appropriate statistical test. There are lots of decision trees that you can find with basic searches online. And finally, there's no substitute for reading to ensure that you are using a valid statistical approach. Also, consult experts if you have questions. This is one such decision tree that I have sort of made from different sources. And so we're going to use this decision tree and work through a selection of an appropriate statistical test, and then talk about reporting the results of that test and interpreting them in terms of conclusions. So, assessment question 7 is going to start us off on this pathway. Which of the following would be an appropriate statistical test to compare the proportion of patients that experience the primary outcome, known clinical failure at 10 days, between our two cohorts, the cephalexin cohort versus the Bactrim or ciprofloxacin cohort? A, Student's t-test, B, the Mann-Whitney U-test, C, chi-square test, D, Pearson correlation, or E, none of the above. So the first thing we need to think about here to answer this question is what type of data we're working with in terms of our primary outcome. So known clinical failure is really a dichotomous answer. It's either yes or no. And so this is nominal data. And we can go to our decision tree, and if we go over to nominal data, we see that the chi-square test is the preferred statistical test for nominal data, except in circumstances where one of our cells in the chi-square table has an expected count of less than 5, in which case you would use Fisher's exact test. So the chi-square test is the test that we would like to use to compare the proportion of patients that experience our primary outcome between cohorts. So reporting results, and then we'll go through our chi-square test. In terms of statistical testing and inferential statistics, a clinical question comparing an outcome between two groups is reformulated as two different hypotheses. So the first is a null hypothesis, typically denoted H0, that there is no difference between the outcome of interest and the groups being compared. And two, an alternative hypothesis, typically denoted H prime, that there is a difference between the outcome of interest and the groups being compared. And then we are going to run whatever our appropriate statistical test is. In the circumstance we just discussed, it's the chi-square test. And this test is going to output a test statistic. So examples of test statistics include a t statistic, a z statistic, or a chi-square statistic, for example. These statistics are then converted to a probability on the basis of the probability distribution for that particular test statistic at a given number of degrees of freedom. And so if you look at the right-hand side of this slide, you see the chi-square probability table that we talked about earlier. And the way that this used to be looked up is we would find here under 7 degrees of freedom at a p-value of 0.05, our test statistic is 14.07. And so we would compare the test statistic that we got to that in the table to determine a level of statistical significance. This probability, the p-value that we find, is the probability of the observed difference between groups or one more extreme occurring by chance if the null hypothesis is true. So this is a really important point. Recognize that the end of this sentence is if the null hypothesis is true. And so basically what we're saying here is the null hypothesis is that there is no difference between these two groups. So if that is true and we have a p-value, and let's say it's 0.04, then that's the probability that the observed difference between groups or one more extreme occurred by chance. And in this case, it's going to be statistically significant even though there is no true difference between groups. So the p-value is used in conjunction with a predetermined acceptable alpha error to indicate whether or not the null hypothesis should be rejected. For p-values that are less than the predetermined alpha, typically those that are less than 0.05, the null hypothesis is rejected in favor of the alternative hypothesis. Rejection of the null hypothesis is typically reported as a statistically significant finding. So it's important that we talk briefly about exact p-values versus the sort of dichotomous significant versus non-significant paradigm. Previously, and as illustrated in prior slides, p-values were determined from probability tables for test statistics. However, today we use modern statistical software packages, and they can report exact p-values. So in current practice and publication of results, typically it's these exact p-values that are reported. And this, in general, allows for better interpretation of the results in light of the sample size and observed effect size. However, the use of the dichotomous significant and non-significant paradigm is important today for setting a priori criteria for the acceptable role chance can play in our hypothesis testing. It has, however, been suggested that inexact reporting of p-values leads to inappropriate association between significance and truth. So recognize that a small study may not be able to generate a small p-value due to its design, but in truth there may be a difference between groups. So recall this is a type 2 or beta error, and this would be common in underpowered studies. Additionally, there remains the risk of a false positive finding, a type 1 error or alpha error, even in large, well-designed studies. So really, we should be reporting exact p-values in terms of statistical significance rather than simply saying something is a significant finding or a non-significant finding. As an example here, going through the same hypothesis testing example that we started previously, we want to compare the rate of known clinical failure at 10 days between these two groups. And so we're going to establish our null hypothesis, which is that there is no difference in the proportion of patients with known clinical failure between those treated with cephalexin and those treated with either Bactrim or ciprofloxacin. And we have our alternative hypothesis that there is, in fact, a difference in the proportion of patients with known clinical failure between those treated with cephalexin and those treated with either Bactrim or ciprofloxacin. Confidence intervals are an additional tool that we have to tell our viewer more about our results and to learn more about our results ourselves. So confidence intervals are going to provide a range of values that is likely to contain the true value for the population from which the sample was drawn at a specified confidence level. Confidence intervals are useful in addition to p-values in that they provide a range of the likely true maximal and minimal effect size of exposure on the outcome being considered. So recognize that when we're comparing a difference between the observed means of two groups, that confidence intervals containing the value 0 are non-significant at the specified alpha level, as 0 is representing no difference between the means of the two groups. However, when we are conducting a statistical test that produces a relative risk hazard ratio or odds ratio as a result, confidence intervals that contain the value of 1 are non-significant at the specified alpha level, as 1 is going to represent equivalent hazard, risk, or odds ratio between groups. So let's briefly talk about confidence intervals and their design and interpretation, and then we're going to return to our statistical testing and reporting of results. So superiority studies are designed to detect a difference between two treatments or more treatments. And so here, if we look at this graphic of confidence intervals, you can see the top row is a confidence interval that does not include 0 and is in fact well to the right of 0. And this is showing superiority of whatever the new agent is there on the x-axis. The second confidence interval down is showing something that has barely met the criteria for superiority, and that its p-value is 0.05, and it just abuts the value of 0 but does not include 0 as a value. And then finally, the confidence interval in the bottom row is including the value 0, and so this is not demonstrating superiority of whatever the new agent is, because the confidence interval contains no difference between these two outcomes. Non-inferiority studies, on the other hand, are designed to demonstrate that the therapy being tested is no worse than the comparator. And so often when you're thinking about retrospective research, you're having to design your study on the basis of selecting between conducting a superiority study or a non-inferiority study. And so when thinking about non-inferiority, recognize that you have to establish an acceptable clinical difference a priori, but that only one tail of this test really matters. So that's the lower bound of the confidence interval here. And so if we look on the left-hand side, you can see the top confidence interval includes 0, which means that there's no superiority demonstrated for the new agent. But importantly, it does not include whatever this negative delta value is, and this is the acceptable clinical difference. So because it does not include that acceptable clinical difference, then non-inferiority is shown, in that it didn't break the margin for being inferior. And then the bottom confidence interval there includes both 0, meaning no superiority here, and it includes the value of the entire negative delta range, meaning that the lowest effect size possible is outside the bounds that we set for our acceptable clinical difference, and therefore it did not demonstrate non-inferiority. Note that non-inferiority studies did not restrict us to only showing non-inferiority, but that would be included in your power calculation. You can still show superiority with non-inferiority studies. It just requires a confidence interval that does not only not contain the negative delta range, but also does not include 0, in that there is a difference demonstrated between both groups. Finally, equivalent studies are designed to exclude a clinically meaningful difference between treatments. And so, interestingly enough, this is the most difficult and narrowest confidence interval to come up with. So you have to choose an acceptable clinical difference a priori, again, as with non-inferiority studies, but you have to consider both the negative and positive delta in this consideration to demonstrate equivalence. So equivalence would be shown if the entire confidence interval were contained within this negative and positive delta range. If it breaks in either direction, equivalence is not shown. So most studies are going to be superiority studies by nature. If you specifically want to demonstrate that something is an acceptable clinical alternative but doesn't necessarily need to be a superior clinical alternative, then selection of a definition of acceptable clinical difference a priori is going to be an important part of your methods. And just as a note, the article that I used and pulled these figures from is a really excellent article on this topic, and so I would definitely recommend it if you are trying to decide on a study design and whether you are really looking for superiority or non-inferiority. So returning to our example of hypothesis testing, we have decided that the chi-square test is the appropriate test for our comparison of our outcome of known clinical failure at 10 days because it is a nominal outcome or nominal data. And so the right-hand side of this slide shows the output from a statistical software package, and highlighted is the Pearson chi-square statistic. So this is the test statistic, which is difficult to interpret on its own, and so the software package has interpreted it for us by reporting out the asymptotic significance, and this is a two-sided p-value that has a value of 0.296. So additionally, we can conduct a further test to provide a confidence interval, which is going to give us additional information that the p-value does not give us. So it's going to provide an estimate of the risk, and also it's going to provide a lower and upper bound for the confidence interval, which give us a maximal and minimal effect size estimate for the overall population. So here you can see that the odds ratio is reported as 1.4. And then we have a confidence interval where our lower bound is 0.74 and our upper bound is 2.6. And so this includes the value 1, which is telling us that there is no statistically significant difference between these two groups. But it also provides us an estimate of overall effect size. So which of the following are true regarding hypothesis testing in this particular example? A, only the p-value should be reported as it contains all the same information as the confidence interval. B, Only the odds ratio and associated confidence interval should be reported, as they contain the information necessary to determine statistical significance, rendering the p-value unnecessary. C, the null hypothesis should be accepted. D, A and C, or E, B, and C. So the answer here is C, the null hypothesis should be accepted. So complete reporting of this outcome would be including both the confidence interval and the p-value. So we have an odds ratio of 1.4 with our associated confidence interval that includes the value 1, and then our p-value is also reported to the right. As a result of our confidence interval including the value 1 and our p-value being greater than our pre-specified alpha of 0.05, we're going to accept the null hypothesis H0 that there is no difference in the proportion of patients with known clinical failure between those treated with cephalexin and those treated with either Bactrim or ciprofloxacin. So that brings us to the conclusion of this presentation, and we've discussed all of the different components that we set out to discuss. Thank you very much for your time, and I hope that this was a helpful review of some practical statistics for clinical research.